Welcome everybody to our Scale Neonatology Education Programme. So this is the second virtual grand round of 2023, and today's topic is going to be about apnea of prematurity. My name is Kath Harrison. I'm a neonatologist based up in Leeds, which is in the West Yorkshire and Harrogate LMNS, and I'm the clinical lead for Scale Neonatology. And I'm sure people who've joined the grand rounds before know that this is a phased educational programme of shared learning between Health Education England and the Ugandan Health Alliance. I'd like to introduce Florence, Oyella and Christine, who are from Gulu Hospital in Uganda, and they're going to be starting with the first talk. And as I said, the topic today is about apnea of prematurity. So I'm going to hand over to Florence. So thanks very much, Florence, for joining today and agreeing to present, and I'll hand over to you.
Hi, everyone. I want to take this opportunity to welcome everyone on Zoom. Gulu Regional Referral Hospital is privileged to have this topic shared, and it comes from the background of, as a result of improved modalities, we tend to see survival of preterm babies of lower gestational age, which contributes to more prevalence of apnea of prematurity in the NICU. And this is how we picked our topic. And I am going to present this with our sister nursing officer in charge of the NICU. And I request her to be the one to take us through the objectives. She will also take us through the history of the mother. I will only take it on when it comes to examination of this newborn in the NICU. Christine, you're welcome.
Thank you, Doctor. Good afternoon, members. Christine, in charge of hospital.
Our topic today is apnea of prematurity, and our objectives of this topic are: 1, to create awareness on the existence of apnea of prematurity. 2, we want to improve on the clinical care through early detection and management of apnea of prematurity. Today we are presenting a case of AS. She's Anena Susan. Anena Susan is a 29-year-old mother who has no medical clinical condition. She's her obstetric history. She's a 29-year-old mother. She attended antenatal 5 times, and by the time of this incident, she was 20. Her pregnancy was 28 months old. During antenatal, she received folic acid, she received ferrous, she received Fansida. She was also the one.
She tested negative for HIV and syphilis. AS had a blood group testing that was A positive and HB of 11.3. AS felt the liver-like pain and some bleeding on the 12th of March, which prompted her to come to the hospital, where she was admitted in our dying ward. She was managed, but this pain intensified, which proceeded into response. Tenus vaginal delivery to a live infant, female infant, with an upper burst of 7 at 1 minute and 9 at 5 minutes.
So, sorry, Florence, just to interrupt, is it possible just to, this sounds like there's quite a lot of echoing from your room. I don't know whether there's anybody with any other screens or telephones on or anything, but it's really echoey and difficult to hear.
I think I've worked it out that we had 2 microphones on for Florence and Christine. I think Christine's is better, so if Florence can mute the microphone on her account and Christine's is unmuted, that would work.
Okay, perfect. Thanks, Tim. So do you want to just try that, Christine? Tim, can you sort out the mics?
Thank you. Hello, hello everyone.
Oh, that sounds better. Yeah, thank you.
Much better, thank you.
We can continue now.
Yes, please.
The immediate care for this baby after delivery was put on the chest, the mother's chest for kangaroo. The cord clamp and cut. The face was wiped and the body dried, changed to warm cloth. This baby was transferred under a radiant warmer, and we connected up patient's monitor for vital observations. The baby presented with a heart rate of 128 beats per minute, breathing of 50 breaths per minute. The weight actually was 1,020 grams. The baby's SpO2 was 72%, and the baby has acrocyanosis. So this baby, we gave her vitamin K, 0.5 milligrams IM. We also applied tetracycline I ointment. We sent information. The staff in Gain sent information to us in NICU that we should prepare to receive this baby to our NICU. Meanwhile, in Gain, they wrote our transfer, the baby's transfer note. We maintained this baby on the patient's monitor and under the radiant warmer. Immediately, NICU was ready to receive the passed us information where we transferred this baby to NICU for the care, prematurity care. Thank you, members. Let me hand you back to Dr. Oyella to go through examination.
Yeah. So we received this baby to the neonatal unit for the preterm care, where we reweigh the baby again, and we confirm the weight. This time we found baby had developed hypothermia of a temperature of 33.3 and had blue peripheries. And the respiratory system was most affected, had SpO2 of 88% on air, and baby was tachypneic with a respiratory rate of 68, had nasal flaring, chest recession with equal air entry. The rest of the system were stable. We went on and did Ballard score postnatally and confirmed a gestational age of 28 weeks. That was on day 1. Yep. So we made a diagnosis of very low birth weight, the very preterm with hypothermia, respiratory distress syndrome. We straight away did a random blood sugar, which had a 3.2 millimole per liter. We started supportive care of keeping baby warm. We received baby in a radiant warmer. We gave D10, started baby on CPAP, and also passed a nasogastric tube, in this case to deflate the stomach since the baby was on CPAP. We also started aminophylline on the baby since that is what we give routinely to our preterm babies to prevent apnea of prematurity. We started presumptive treatment of ampicillin and gentamicin. which are the first line drugs for treatment in the NICU. We connected baby to a cardiopulmonary monitor, still for vital observation. Baby progressed well until the 6th day of life. While we were on the ward, we heard the mother shout, "Help, my baby has died." So when the team rushed to her cot, we found baby had ceased to breathe, and the monitor was recording a heart rate of 82 and oxygen saturation of 86. In the process of preparing baby to start the bag mask ventilation, baby with the stimulation, baby was able to start breathing. Baby had 3 episodes of cessation of breathing, which we noted within a period of 8 hours on that 6th day. So a diagnosis of apnea of prematurity with respiratory distress syndrome in a very low birth weight preterm was made. We also ruled out a late onset sepsis. So we had to do a CBC, which is complete blood count. We took sample for blood culture, and being a preemie, we sent baby for cranial ultrasound, rule out intracranial bleeds. The results are as displayed. We had total lymphocyte counts of 28.8. We were mindful about baby being a preterm and on at least 6th day of life. So we compared these results with the protocol, which we have on the ward, and a neutrophil of 12 times 10 was a little elevated beyond the normal range. Even the platelets, the HB was a little low, which we thought was as a result of the mother having bleeding before the APH before the delivery. We were also mindful about urinary tract infection, but that gave us a normal test result. Cranial scan was normal, and we thought of upgrading antibiotics to ceftriaxone and ampiclox as we wait for culture results. Important point that this case raises. Obviously, we know that neonatal mortality remains unacceptably very high, especially in sub-Saharan Africa, where Uganda is amongst those countries. And apnea of prematurity remains a common complication in the extremely and very low birth weight preterms, and this contributes highly to mortality and morbidity. And the question we asked ourselves is, of the babies admitted to Gulu Regional Referral Hospital to NICU with prematurity, how many of them die because of attributable apnea of prematurity? With that question, it is therefore important to predict and watch for apnea of prematurity in all the preterms that we admit in our NICU. But positively, it is also important, as was done, that every preterm babies are initiated on aminophylline. We wish we had caffeine, but since we only have aminophylline, this is what we initiate our babies on. We start them on antibiotics presumptively and monitor their vitals. However, our facility doesn't have conventional CPAP and ventilator, so the far we can go is to put our babies on improvised CPAP. The best practice that we have in Gulu is, before babies are brought to NICU, we must get information from the delivery points. Like in this case, Gyne ward had to give us information about this baby to be brought, and all the extremely low birth weights and the very low birth weight preterms are initiated on oxygen. If the respiratory distress are severe, we start them on CPAP. If they are mild, then they are started on prongs. And all the preterm babies admitted to NICU are connected to cardiopulmonary monitor until when they are stable, because we want to constantly monitor their parameters. The nursing team in our unit at Gulu have been empowered to initiate at least the first doses of drugs like the aminophylline and the antibiotics. We have SOPs which are on the NICU, so at least that guides the calculation of the doses. And there is involvement of mothers or caretakers to also join in the observation, especially if we suspect apnea of prematurity, so they can shout for help and we turn up immediately. And we also do the airway breathing circulation check for all collapsed babies. So we do the rightful intervention. And lastly, not least, kangaroo mother care is initiated as soon as babies are stable, and we shift them to the kangaroo room. The guidelines on the management of apnea of prematurity that we have is to initiate our preterms on CPAP, especially those that we suspect to have apnea of prematurity, as well as RDS. We initiate them on aminophylline and put them on cardiopulmonary monitoring. And should a baby develop apnea, we start with the tactile stimulation, which can be done by even the caretaker before the medical team arrives. Thank you for listening.
Thanks very much, Florence and Christine. That was a really clear presentation about obviously a very common situation that we all find ourselves in. And I thought what was really nice was that you've shared some really important learning about looking for the different causes of apnea before you just start the aminophylline, but thinking about intracranial bleeds and infection. So that was a really nice example. Are there any questions for the Gulu team? You could just put them in the chat, or you can raise your hand and please feel free to ask questions. These sessions are for everybody to participate, and it's really important to get your questions and views on that, so feel free to type anything. Could I just ask you, Florence and Christine, you mentioned about that the nurses took the initiative to give the first dose of treatment. Is that before a doctor prescribes that? Would they just give that before that happens? How would it work?
Yeah, thank you. Usually it is before the doctor prescribes.
Okay, that's interesting, because I think in the UK we're not that proactive. We would have to have it prescribed before we give it. So I think that's really interesting, because sometimes it's difficult, isn't it, waiting for people to prescribe in terms of timings. So there's a question in the chat just saying thank you very much for the presentation, and how is the baby doing now, and are you still giving the antibiotics, was the first question.
Yeah, we are grateful to inform our team that we discharged baby yesterday with a weight of 1,320 grams, and the mother is able to continue care at home. She has adhered to kangaroo mother care very well, and her next review date is on Tuesday next week.
Thank you, that's really good to hear, Florence. Another question is, why did you use ampiclox? Which organism were you targeting?
Yeah, Why we used AMPI clocks, we were thinking of hospital-acquired infections, which includes staphylococcal infection. And because we didn't have clocks in isolation, we had to choose the AMPI clocks, which was available for the mother at that time, pending, of course, a culture results. Thank you.
Thanks, Florence. So another question in the chat before we get to Jonathan's question was Sam wanted to know whether antibiotic eye ointment is routine. Obviously, we wouldn't do that in the UK, but from my experience working in Uganda, you would. But what were your thoughts on that?
Please repeat to me the question. I didn't pick you well.
It was just about why you use routine topical eye ointment for your babies.
In Uganda, that is what is in our policy guideline to protect them from ophthalmia neonatarum. So, like we give vitamin K to every newborn, we equally give tetracycline eye ointment as prophylaxis.
Yeah, thank you for that, Florence. Jonathan, you had your hand up with a question. Jonathan Sakito, you had a question for us, did you?
Yeah, thank you so much. The presenter and the moderator for the nice presentation and the discussion. I just wanted to find out two main things. One, did we manage to get the culture results and possibly change the course of management, especially with antibiotics? Then number two, after discovering that this child had apnea, and remember the child was already on aminophrin, the prophylactic one, was there any change in management of apnea? Maybe adjust the dose of aminophrin. I don't know, what else did you do? Because apnea happened. Was it, if it wasn't intracranial bleed, it wasn't infection, maybe it was the apnea of the prematurity that was expected. What more did you add on management of apnea apart from other supportive management? Thank you.
Yeah, thank you, Jonathan. We didn't actually had any more medicine to treat apnea, except we remained vigilant to intervene with the tactile stimulation of the baby and continue to monitor for the length of that apneic episodes. At the back of our mind, yes, we queried, could it be a late onset sepsis, like a hospital-acquired infection? And that's why we also ruled out any intracranial bleed. Anemia could have as well explained, but having HB level of 11 and the baby was stable on CPAP, not on conventional ventilator, the protocol would not allow for the baby to be transfused. So we thought it was the apnea due to immaturity of the respiratory control system. Thank you.
Thanks, Florence. Kathy, you've got a question.
Yeah, thanks, Kath, and thanks, Christine and Florence, for the presentation. I just wanted to raise the point about caffeine, really, Florence. Some of us, and you may not be aware, and it goes to everybody on the call, really, some of us have been advocating quite strongly to have caffeine available, at least in the regional referral hospitals across Uganda. And as of about the middle of last year, even in Bali, we've managed to get some caffeine. It's by no means enough, but a little bit is a start. And as we all know, a little becomes a lot. We use the caffeine from NMS via the hospital pharmacy. We prioritize the little caffeine that we have for babies under 1 kilo or babies under 20.
Just losing connection a bit,
but
Kathy,
if baby is still having apneas, on switch the baby over to caffeine. Very, very old drug, and most of the evidence is. Let me type.
Okay, we'll read it out. But I think what we would do, and I think Matthew will cover it in his presentation, is we would use caffeine or respiratory stimulant up to about 34 weeks gestation. But I think Kathy is going to put something in the chat. And then just one final question, Florence. It's not massively about the apnea of prematurity, but there's a couple of comments in the chat about, you said the baby went home at 1.3 kilos, and some of the discharge sort of guidelines say that they should be a bit bigger than that. And so some of the questions are, why did you send the baby home when the baby was so small? I presume the baby was growth restricted, so was relatively mature, but just tiny. So we'd be interested in your comments on that, please.
Yeah, we sent the baby home with a weight of 1,320 grams. The protocol guideline that we have allows for discharge at the weight of at least 1,200 grams, so long as the mother is competent to continue care at home and she has adhered to kangaroo mother care, which is going to be the main source of heat to the baby. And such preterms, we usually make them come back at least within a period of 1 week. This very mother stays at a distance of less than 1 kilometer from the hospital. We do also tell them in an event, baby should be brought back, not necessarily waiting for the 1 week. Thank you.
Thanks very much, Florence. So there's just some guidance from Kathy's hospital in Mbali that's about discharge criteria. So that's helpful for everyone to read in the chat. I'm going to hand over now to Matthew, who's one of our consultant paediatricians in our West Yorkshire and Harrogate LMNS, and he's also going to talk about a case and how we would manage apnea prematurity in the UK. Thanks, Matthew.
Thanks for that first talk. So yes, I'm going to pick up on apnea prematurity. I'm not going to do a case. Also, just apologies, one of our nurses, Rebecca, was going to join today, but she's had to been rostered in to help on the unit, so I'm on my own today. But if there's any nursing questions, I will do my best. Anyway, so apnea prematurity. So I'm not going to do another case, but I will pick up on some comments about the first case, because obviously there's sort of similarities in terms of the babies we get. It's just what we do with them afterwards. So there we go. So just to explain a bit about where I work. So I work at Airedale, which is part of the Yorkshire Neonatal Network. We're a special care baby unit. So in the UK, there's sort of 3 levels of units. We're in the smallest level, level 1. So this means we wouldn't routinely keep a baby below 32 weeks. So the baby that was mentioned in the first case, if they were born here, they would be transferred out within a few hours of birth to one of the big units, and probably would actually be ventilated and transferred rather than put on CPAP. Although some babies would be managed on CPAP, but they would, for us, that would still require a transfer out. So we can keep babies above 32 weeks. And we do keep babies on CPAP and other high flow nasal cannula oxygen if needed. But anyone below 32 weeks ideally would have been transferred in utero within the Yorkshire network. So our nearest bigger units are Calderdale in Bradford. We also work closely with Leeds, particularly the subspecialties, including neonatal surgery and cardiology. We're very lucky we have a regional specialist team that Kath's involved with called Embrace. They're about 40 miles away. So in terms of Yorkshire terms, we're quite a long way from Embrace, but I know realistically we're not that far from a lot of specialist services. This is just an idea for anyone who doesn't know our region. So let me just put a little pointer on. So yeah, Airedale's here. So we're sort of on the edge of the network. So this is sort of the Yorkshire area roughly. We're on the edge. So if you go beyond us, and it's just really hills and sheep. There's not much up here, but we're not far from the sort of biggest centres of Bradford and Leeds and Calderdale. So we've got sort of a 12, 20-mile journey to one of the big centres roughly, and Embrace are based down here on the motorway. So they would come to us, pick up a baby, and then take them to one of the other big units. So that's how we work across Yorkshire. But I've got the advantage of having trained in Yorkshire. I've worked in all these hospitals in the past, so know people well across the region. So it works very well for us. So apnea prematurity, so we've already discussed it's a common problem in premature babies. I'll talk a little bit about the epidemiology and why it happens, and also talk about the long-term effects, because that is in some ways the, sort of the reason we try to treat it. And as we've already touched on, really, in terms of straightforward apnea prematurity, caffeine is beneficial. I'll come on to the details of that, but it's clearly something that I know Kathy just touched on, that probably if there's one thing you would like to develop, it would be routine use of caffeine. And other issues, I will talk about some of the other things that can cause apnea. Then we've already talked about those, so I'm not going to go into detail, but again, just some of the things you have to think about rather than just putting apneas down to prematurity. So there are various definitions, but generally, if you look at papers, most people would say any cessation of breathing for more than 20 seconds is a neonatal apnea. But of course, some babies, it can be shorter than that. And if they become bradycardic with a heart rate of less than 100 or pale or cyanosed, that's also significant. And often, that will happen in babies. It's a common problem in neonatal units. So if you look at the literature, below 28 weeks, pretty much all babies get apneas. It's sort of something that happens to all babies at some point. And certainly, in terms of the babies we transfer out, they're the ones who have more problems. So we're quite lucky already, because our babies are sort of generally 32 weeks and above. So the babies we keep, it's not usually a massive problem. They may be on caffeine, it may be a bit of an issue for a few weeks, but they tend to grow out of it. Clearly on the bigger units, it becomes more of a problem, particularly when you've had a baby who's been ventilated and you've just weaned them off, it might be more problematic. Of course, one of the things with monitoring breathing and saturations is the more you monitor, the more you're going to diagnose it. And we all know from in our practice that where babies are routinely monitored, babies constantly have sort of fluctuations with saturations and drop the heart rate slightly, and then it'll come up, and it often doesn't need any intervention. So of course, the more you monitor, the longer you monitor, the more you'll pick it up. And even babies beyond 34 weeks will have the odd desaturation and maybe apnea, but it becomes much less of a problem beyond 34 weeks. The other groups to look out for is the babies with BPD. So certainly it's perhaps not as bad as it used to be, but I remember sort of in my training, babies with really severe chronic lung disease that could have really bad apneic episodes, desaturations, often needing bagging and oxygen to bring them round. And that's something that we still see with some of the very small sort of premature survivors. And obviously, again, it's another reason to monitor them closely. And the other thing is actually, is it harmful? And you think, well, it must be harmful. Babies are dropping the saturations, they're not breathing, it can't be good for them. But actually, if you look at long-term studies, it's hard to separate that out from prematurity. Being born prematurely is a risk for lots of long-term problems. So how much of it is it the apnea? How much is just because they were born prematurely? In terms of what happens, well, in most babies, it's a mixed apnea. So it's generally the central drive to breathe is just insufficient. The breathing centers in the brain are immature, and the baby just has a pause in its breathing. What tends to follow on from that is, at the same time, the baby babies tend to be quite floppy. We know they've got difficult airways. Often the reduced airway tone means they'll obstruct their airway at the same time. So it's a mixed apnea, although it originates from the brain. As I just mentioned, it's sort of, if you're looking at long-term effects, it can be hard to separate the effects of being born prematurely from those of apnea, because if a baby is very premature, they're the ones who are most likely to have had lots of apneas anyway. And that's where caffeine becomes interesting, because that's where we do see a benefit. And of course, if you're doing any research, you really need long-term studies, because we know with lots of neonatal problems, getting babies to discharge is one thing, that's always a success, but then you're looking at the long-term outcomes as well. And if you can do anything to improve long-term survival and reduce the disabilities, that's obviously where we should be looking at further research. So this is a nice slide, just sort of summarises what I've discussed, and this is from a paper from 2021. It's freely available online. It's a free publication, and it just sort of shows that cycle of babies being neurologically immature, having apneas, and all the other problems that go along with it: poor airway maintenance, insufficient respiratory drive, all as a result of being born prematurely. And this all feeds into the neurological damage, which further down the line, because of the hypoxia and bradycardia, can cause cerebral palsy, developmental coordination disorders, other learning difficulties, behavioural problems later in life. And obviously, the more preterm a baby is, the more we're looking at these problems as they get older. And we know that even in babies who have very successful resuscitation, good intensive care from day one, they still have an increased risk of neurodisability later in life, particularly more extreme prematurities. So how would we treat it here? And like I said, so in terms of my experience, what I see in Airedale is, well, on the whole, is fairly straightforward, because we're looking at babies 32 weeks and above that don't tend to cause too many problems. But I've also got experience from bigger units where smaller babies can be more problematic. All our babies routinely monitor for the preterm, so they'll have continuous pulse oximetry and also an apnea alarm, which is a sort of little sensor that sits under the mattress. If in the first day or so, if a baby's on any respiratory support and on more monitoring, they may also have the ECG lead, which also can pick up respiratory movement, so that can also pick up apneic episodes. But as they're stabilised, we wouldn't routinely keep them on full monitoring, but they would have a pulse oximeter and an apnea alarm under them to look out for breathing irregularities. The newer machines tend to be better than the old ones. That we know that babies move around and you get a lot of artifacts on pulse oximetry. The machines are sort of generally better at picking that up, but then they're still not perfect, and a very active baby can often set off the alarm, and that's something that obviously is important for training for both staff and for parents. And we always tell people, look at the baby, not the monitor, because often the machine reading just doesn't correlate with the baby, and we don't want people getting over anxious about little desaturations. Most babies we see, these episodes are self-correcting. So in a baby, we just have sort of a brief apnea desaturation, then corrects itself. We wouldn't be rushing in to do lots of tests if the baby is otherwise well, but clearly there are situations where you do need to think about sepsis and other problems. As Florence mentioned, sometimes it just simply needs a bit of stimulation from the nurse just to get the baby breathing again. Obviously, if they're more hypoxic, you might want to give them oxygen. That should be done with caution, really, because certainly if you've got a baby who's having lots of apneas, if you stick in an oxygen mask on the face every time, then that we know that the oxygen control mass is a relatively high inspired fraction of oxygen. So you've got to think about the risk to the baby, including ROP. I think what we sometimes find is you sometimes get babies that are, they are improving, and the stats sort of dip up and down perhaps without major desaturations, major apneas, but just a little bit of oxygen in the incubator can just sort of seem to stabilise them. So though that's not evidence-based in terms of practical things, that often helps. But again, I recognise that just having a little bit of oxygen in every incubator, it can be a luxury if you've got shortages of these things. Obviously, we do have access to non-invasive ventilation, both CPAP and high flow. It would be unusual for one of our babies that they would, if they've been previously well, they would need one of these. I mean, if a baby that's never been having respiratory support needed high flow or CPAP, we would certainly be looking for infections, IVH, etc. Some other reasons for deterioration. What we do tend to see is babies where perhaps they've been weaned off ventilation, that perhaps they're just not quite stable enough. And certainly we find keeping them on high flow is sometimes good for the very small babies with chronic lung disease, because they are still a bit fragile, and just it's quite a nice to the high flow. The nasal they can still be out for feeds, they can be managed quite normally, but just have that little bit of support that just does seem to reduce the number of apneas that they have. In the bigger units, if you've had a baby who was on a mechanical ventilator and then failed extubation or was having severe apneas, they may go back on. But again, you would hope that most babies you would be getting them off when they're ready to be off. And of course, now with high flow and CPAP, we'd probably see a few babies going back on the ventilator. Anemia has been mentioned. Looking at the research of this, it's quite interesting. So certainly babies who are anemic are more likely to have apneas. And so therefore you suddenly think, well, it must make sense to treat it. But in fact, the research suggests that if you treat a baby, give them a transfusion, it probably only makes a difference for a few days in most babies. So actually what you should be looking at is the overall risk benefit of transfusion. So if a baby is very symptomatic from the anemia, well, again, we have guidelines in terms of which baby should be treated depending on gestational age and option requirement. So if they're meeting the requirements of transfusion, to clear long-term benefits from transfusing them, you don't want a baby to be struggling. But an apnea would be something that comes into that, but you wouldn't necessarily treat them on apnea alone. So, I mean, most of our babies that get transfused in our unit tend to be the ones who have been transferred back from one of the bigger units. They were probably ventilated for a while, have had lots of blood samples, etc. So they've got anemia of prematurity, and we often find that they do need to be transfused once or twice just to sort of top them up, really. And then caffeine, which I'm going to come on to in more detail. So caffeine is the standard treatment in the UK. It's been used for a long time, but it was incorporated into this guidance. So in the UK, we have some national guidance on neonatal topics. It's not a huge number of things that are covered by this, but there's something called the National Institute for Health and Care Excellence, called NICE, and they publish national guidance, obviously with expert recommendations based on the evidence on important topics. So this one was published a few years ago, and it covers all of respiratory care. So it talks about things like when to give surfactant, maternal steroids, and caffeine is one of the things that's mentioned in the NICE guidance. So we follow this. Like I said, caffeine was used a long time before that, but it has sort of been standardised pretty much by following NICE guidance. We also have some guidance within the network, the Yorkshire network, which is very similar to the NICE guidance. And we also have a drug monograph, which I will show you. Just to standardise care across the network, really. So we're all doing hopefully the same thing. So caffeine, as we've been before, aminophylline. So caffeine and aminophylline, both these methylxanthines, they both work in the same way. They basically make the baby's brain more sensitive to carbon dioxide. So as the carbon dioxide increases during an apneic episode, they will breathe more quickly than if you left them to do it on their own. So the baby just isn't very sensitive to that rise in CO2. And if you give them caffeine, they will be more sensitive to that, so they'll hopefully breathe sooner. It's also been shown to improve diaphragmatic contractility and even cardiac output. So if the baby does have an apnea, the idea is that the baby will breathe more quickly and hopefully more effectively, and even maybe generate an improved cardiac output just to keep the blood flowing to the brain, which is really what we're talking about here. It's been used for a long time, since the 70s, but it wasn't until 2006 that the big study called CAP study, Caffeine for Apnea Prematurity, was published. That had a couple of thousand babies, and it was the first real big study that sort of showed some evidence from some benefits from caffeine. What they showed in that study was at 18 months, there was a reduction in cerebral palsy and also developmental delay. Now, some of that was related to the fact that the babies who'd had caffeine were also ventilated for a shorter period, because you find that a baby who's on caffeine tends to get off the ventilator quicker, and being off the ventilators quicker is also good for the baby. So it's sort of a double benefit, really. The caffeine itself is good, but then coming off the ventilator earlier is good. They also did some longer term follow-up, and I think actually they followed up beyond 5 years. I think they went up to 11, but even at 5, there was reduction in developmental coordination disorder. So that's if you go into the NICE guidelines, they give like a detailed analysis of all the evidence, and that's obviously features highly because that's the sort of the big study that had been a driver to sort of increase caffeine use. The other thing to think about is also long term. You know, we're all aware of things that, you know, perhaps help in the short term, but again, with a developing brain, we've got to be careful. But there's no evidence of any long term harm from caffeine. I think the only thing which is sort of perhaps a minor side effect is it can make reflux a bit worse. And I'll talk a bit about reflux afterwards. But generally, it's the situation where the benefits outweigh the risks, and it's routine use in the UK. So what do we do? So NICE recommend that any babies below 30 weeks get caffeine routinely. Start early, ideally before 3 days old. It's sort of certainly going back, you know, perhaps 10, 20 years, it perhaps would be that babies were ventilated for a while, and it was only that when they were going to be activated, they would be put onto caffeine. Now, because we try to get babies off the ventilator quicker, and certainly although we would transfer babies out, your babies will be on having caffeine while they're on the ventilator, with an aim to help get them off quickly. But the NICE guidelines do recommend considering it for any baby with apnea, any preterm baby. So certainly we get some babies at even 32, 33 weeks that in the first few days are having apneic spells, and we would put them on caffeine. We aim to stop it, well, in the network, we aim to stop it by 34 weeks. NICE say 33 to 35. We tend to try to get babies off it by 34 weeks. One thing I've not mentioned on here is it can be given both intravenously and orally. The intravenously is relatively expensive, but so we do try to switch the oral quite quickly once the baby can tolerate it. The doses are there, so a bit of a time. We're once daily after a loading dose, 5 milligrams per kilo.
Matthew, sorry, do your slides need to move on? We're just on the treatment, just on the NICE guidance treatment still. I don't know whether it's just got a bit stuck.
Yeah. So can you see the one with the dosage on? Is that the one that's on? No. Strange. Hang on.
We can see one that says treatment and then the NICE guidance, but can't see the ones after that. So
right. It's moving for me. I'll just stop sharing it and reshare it.
Okay, sorry.
Which slide's up now? So that's one with the dosage on. It says NICE guidance at the top.
Mm-hmm.
Is that what you're seeing?
Currently, I've got a black screen. Sorry.
Oh. Strange.
I can see the NICE guidance.
Oh.
Don't know if it's.
So I'll move forward on to the next one.
Sam can see it. It might just be me then, so that's fine.
Okay.
Keep going. I'll wait for Sam.
Yeah.
To
So just quickly across the dosage. So NICE recommend you can get up to 20 milligrams per kilo per day. One of the advantages of caffeine over aminophylline is it doesn't generally require monitoring. If you're on a high dose, you would start monitoring it, but certainly the babies we have, we would routinely monitor the dosage, the levels in the blood, and we would go up to 20. In fact, our network guideline recommends a maximum of 10, although the NICE do say you can go as high as 20.
Yeah.
So that's just the drug monograph we have across the network, which you probably can't see the detail, but as well as the doses, it tells the nurses how it's prepared, so what it's compatible with, how you can give it. So we have lots of these monographs for drugs that we use across the network. The advantage of having the network guidelines is it gives consistency. As I said, we're getting babies moving between units, so it's nice to know we're doing the same thing. So there's some noise in the background.
mute if they're not talking, please.
Do you want? Are you bothered about that now? You didn't need that doing, no, you're not bothered.
Right.
I'll fill them so the holes are filled anyway, yeah?
That's
Everyone make sure that they are muted, please, if you're not Matthew.
Thank you. Sorry for that stress. Yeah, so the other thing which is less of an issue now is there used to be quite a bit of confusion because we kept switching between prescribing as caffeine citrate versus caffeine base. One is twice the dose of the other, which caused a lot of confusion when different units are using different things. But I think we've all now grabbed the caffeine citrate, so that's less of an issue now, but it was always a risk. And we finally got agreement on that. So the other things we've touched on earlier on. So certainly with gastroesophageal reflux is quite a common cause of apnea in babies, but probably it's overdiagnosed. And I think actually in a well baby, I mean, so our approach in the sort of the low risk babies we're dealing with would be, we wouldn't want to rush in and start reflux treatment these days. And again, thinking back to my time as a trainee, it was sort of, there were times when it was almost fashionable to have babies on reflux treatments, and I think we've moved away from that now. It's not that reflux doesn't exist. I think it's just sometimes you've got to accept that babies who are well just do have apneas, and you know, think about the other things first of all. Talking about reflux, one of the things we do know now is acid suppressions, things like omeprazole. It's just worth remembering it doesn't stop the baby reflux, and the milk's still going to come up and irritate the airway, which is why it can cause apnea, but because it reduces the acidity of the pH levels. But there is evidence of increased risk of sepsis and also NEC if you use things like omeprazole. So I know certainly people moving away from that, and I think most units now it's pretty much a consultant decision to start something like that, whereas it pretty much used to be a routine thing not too long ago. Same with thickeners. Again, people are keen to thicken up the feed to prevent reflux, but that's also been linked to NEC, particularly in preterm babies. So it's back to basics of positioning and making sure you're giving a feed volume that a baby can tolerate rather than rushing with medication. We've touched on late onset sepsis. Like I said, for us, it's less of a problem because our babies tend to be more mature. So probably when they are having apneas and desaturations, they're perhaps not as unwell and less so it's less likely to be sepsis. Also, we don't have babies that are still got central lines, having TPN, etc. So in a big unit with a very preterm baby, you know, you're going to have a lower threshold for taking blood culture, starting antibiotics, and certainly in the first few days, you've got a baby having lots of apneas, particularly if they're not having much in the way of respiratory issues. Otherwise, you've got to start thinking about sepsis. But you've always got to have that thought there. And I think same for the IVH. Again, our babies aren't really, but by the time they come back to us, it's very unlikely. But on the bigger units with a preterm baby, you've got to think about bleeds as well. The other thing we occasionally see, although luckily we don't see much of it, is viral infections, including RSV, bronchiolitis. We do occasionally get, we allow siblings to visit on our unit. Most units do now. It's during the pandemic, it was restricted, but you do occasionally see a 3 or 4 year old brother or sister visiting with who's full of cold, and obviously we have to sort of explain to parents the risk. And same for staff and parents. If you've got symptoms of virus infection, you really want to be careful when you're handling these preterm babies, because an RSV infection in the baby could start as apneas, but they could quickly end up with full-blown bronchiolitis and back on a ventilator. So that's something we have to think about as well. And so just sort of highlighting differences here, and I know Kathy's on the course. I just came across this when I was doing the reading, and I know Kathy said that obviously people are looking into getting more caffeine in sub-Saharan Africa. One thing I didn't know about was this WHO list of essential medicines. So there's a list of medicines that are recommended that all countries can have access to, irrespective of income, and caffeine is on there. So that shows how important it is that it's made onto that list. As I said, compared with aminophylline, I've no experience of aminophylline in neonates myself, but the advantages are it's easier to give, and so you don't need to monitor the dosages, and the evidence is there. So it's and I don't know if anyone knows, but I'd be interested to know how come aminophylline is relatively cheap compared with caffeine, because when I started planning this talk, I'd assumed caffeine must be a cheap drug. It's probably something everyone's got access to, and of course I've learned through this that it's not that straightforward. So that's something, if you're interested, again, it's an open access article, so anyone can read that. So there's some of the resources I used. The NICE guidelines, the Yorkshire guidelines are easily available online. These are the other articles that are quite interesting if you want to do a bit more reading. The US also has some national guidelines on apnea, which I did look at. And then the CAP study was, I put the reference here, that was in the New England Journal of Medicine in 2006. So thank you. So got any questions? So for those of you that aren't in Yorkshire, we're in the nice bit of Yorkshire. So this is a bit different to Leeds and Bradford. We're tucked away in the hills there. So if you go over the hill past the sheep, you'll see it just in the background there. And that's why we need ambulances to come over the hills to us sometimes in the snow and take our babies to Bradford or Colesdale. And usually CAFs or one of her teams helping us with that. Thank you.
There's lots of comments in the chat. I think there are lots of papers. Pam's put in a comment that there's lots of papers about that aminophylline equals caffeine in terms of efficacy, but it's actually that aminophylline has got more side effects. And then obviously Kathy's saying that although caffeine is on the essential list of medicines for WHO, it's actually expensive. That's one of the big issues, isn't it? Has anybody got any questions or comments either in the chat or raise your hand for either of our speakers? So Florence, Christine or Matthew, just anything in the chat. But I think it's been really good just to demonstrate that we all face exactly the same situation with babies with apnea, and it's just about making sure that we can treat the treatable, and then when we assume that it's due to apnea of prematurity. So there's a question in the chat for you, Matthew. Thank you, Dr. Matthew. Is there an indication for surfactant in such babies, which may be apnea of prematurity superimposed on RDS?
Well, I suppose in terms of the babies we see, although our cutoff is 32 weeks, if we do have a baby that's below that gestation and being transferred, in reality, most of those babies will actually get surfactants because they're going to be transferred. Generally, it's safe to transfer them ventilated. I mean, we can transfer stable babies on CPAP, but most would be ventilated. So yeah, if they're intubated, they're going to get surfactants anyway. So in terms of our babies, they're going to get surfactants as soon as they're intubated. So yeah, and then they're shipped out. So they wouldn't, by the time they start having their apneas, they're not with us anymore. But I suppose even in the big units, these babies, the highest risk ones, are below 28 weeks. Most of them, even the big units, will have had surfactants, even if it's like Lisa or Insure, where they've only briefly been intubated or for surfactant. Nearly all these babies do get surfactants. Again, that's something that's recommended in the guidelines. Again, we're very lucky that we can give these babies surfactants early on rather than waiting for problems. So really, if a baby continues to have problems, you're going to be looking at the ventilatory support and sepsis, etc. They will probably have had surfactants already. If you've got a baby with very bad RDS, obviously you may be giving extra doses of surfactants as well.
Thanks, Matthew. There's a comment just saying there's lots of neonatologists in Uganda, especially in the regional referral hospitals. So we need to raise the profile and the need for getting some caffeine, because it is actually an amazing drug to work. So yes. Any other comments or questions for any of our speakers? Just give people a few minutes just to type anything into the chat. I put the link to that really good paper that was in Frontiers, which gives that overview about apneas, about the physiology, the current treatments and the future directions, because it's a really nice overview paper if people wanted to access that.
Pamela's just got her hand raised.
Oh, actually, I can't see that. Perfect. Go for it, Pam.
I just wanted to ask, the baby, the first presentation, the baby that was admitted was 33, the temperature was quite low. And I just wondered why that was. Is it air conditioning or, and is it something you thought about looking at? Because that would aggravate any RDS.
Yeah, good question, Pam. Go for it, Florence.
Yeah, thank you, Pamela. The temperature was quite low, I think, as a result of exposure from delivery to the time the baby was stabilized in the gyne ward. The baby was kept in the radiant warmer. But bringing the baby from the gyne ward to the NICU, I think that's where the baby got a reduction in the temperature. Many things could account. If the clothes they used probably for wrapping the baby now as they were bringing to NICU, by conduction, I think could explain the temperature reduction. But immediately we received in the NICU and put the baby in the radiant warmer. The temperature normalized. Thank you.
think what's just important to say for people in the UK is that frequently the delivery suites are not co-located next to the neonatal unit, and most of the time you have to walk outside around different hospital buildings only between the gynae wards to get onto the neonatal unit is very different. There's no down the corridor just through a door, so it's quite common to see hypothermia by the time babies arrive on the neonatal unit. I presume that's the same situation for you, Florence. Jane, you had your hand up for a question.
And thank you for the presentation, Team Gulu. I hope you're getting me. Hello.
Yes.
Hi, Jane, we can hear you.
Yes, we
Yes,
can
thank
hear
you so much. I have a comment or a question. Like we have heard from Uganda, we have very low supply of caffeine from national medical stores. So my question is, if maybe you start caffeine, you give the first dose and it goes out of stock, can you continue with amnoflin? Thank you. Hello.
Hi, do you want to respond to that, Florence? Go for it.
Is it not clear?
You're very clear, Jane.
Okay. Thank you so much.
Yeah, I would answer, but let me give the opportunity to Matthew to answer since he's the one who presented on caffeine. Thank you.
Thank you so much. Thank you.
Well, I suppose if it's not to me, I'm looking at that problem, but yeah, I think essentially they work in the same way. So yeah, you could switch between one or the other. And in terms of the dosages and the timings, I wouldn't know. You'd probably need to get some advice on that. But I think the evidence is that these drugs work in the same way. So you're better off to be on one of them. You might need a bit more monitoring if on amnoflin, would be my understanding. But I think you'd be better off carry on the amnoflin while the baby needs it. Obviously, if they get to the age, let's say 33, 34 weeks, and they're very stable, then again, with limited resources, you don't want to be going on longer than you need to. And even in the UK, we're always thinking about these things here because these drugs are still relatively expensive. So, we don't want to carry something on longer than we need to do it. And what we would do when we stop the caffeine is obviously we can monitor the baby, and if they start having problems again, we would restart it. But we try to stop things as soon as we can once we know a baby's stable enough.
Thanks, Matthew.
Okay.
I mean, there's a comment. I mean, they do work in the same way, but they have very different half-lives. Kathy agrees in the chat that basically what they would do in Mbali is leave 24 hours between the last dose of caffeine before starting amnoflin, because caffeine has got a half-life of it can be in the system for up to 5 days. So to make sure that that's gone before you'd start amnoflin. Jonathan, you had a question or a comment? Jonathan Sekito, question, comment?
Okay, thank you. I was getting a problem unmuting. Yeah, thank you so much, Matthew, for the presentation. I have 2 comments and seeking some clarification. One, yeah, well, how long is recommended for us to keep the children on caffeine? And yeah, I know through our systems actually right now through the NMS and through our medicine and therapeutic committees, we can order some caffeine. So how long should the child stay on it such that it can help us estimate what we need? Then the other thing was it Kathy who said that in UK you don't use tetracycline eye ointment routinely for your babies? Could you kindly tell us why? What informs that guideline, such that maybe we have something to learn? But in Uganda, it's still, for many years, it is part of our guideline that we give every baby that is born. Thank you.
Yeah. Well, for the caffeine, so yeah, so the NICE guidance, which is, I mean, I said if you go into the detail, they do a big sort of study of all the meta-analyses. So their conclusion was to stop it between 33 and 35 weeks. In Yorkshire, we tend to aim to stop it before 34 weeks. So if we've got babies very well, even at 33, 32 weeks, if they're not having any apneas, then we wouldn't automatically carry it on. The benefits are more probably in the very preterm babies. So once they're stable, we would aim to stop it. But yeah, you're looking to stop it by 34 weeks. There'd be odd baby that, say, with severe BPD that may be on it for longer than that. And we do even occasionally use it in bigger babies, and we sometimes get babies admitted. I cover general paediatrics as well as neonates, and we get babies with bronchiolitis with apneas. And if we're really struggling, we'll give them some caffeine, because it does seem to help. Perhaps like an ex-prem who comes in with bronchiolitis, but generally by 34 weeks we will be hoping to stop it. With regards to tetracycline, I don't know. I guess it's just to do with the rate of infection. I mean, it's something we very rarely see. I mean, there is whether it is more screening in mums, I'm not sure. We perhaps on our children's ward we get maybe one or two babies a year with sort of significant sort of eye infections, but it's very rare. We get babies with slightly sticky eyes, but it's unusual for it to need to give any treatment at all. So I'm guessing it's just to do with the population prevalence, but it's not something I know much about.
What it is. Definitely what it is, Jonathan. So obviously you use tetracycline for either gonococcus or a chlamydial infection, and we have very low rates of that in the UK. And generally, we know about women who are infected, and we have guidance from our GU medicine teams. So it's very, very rare. But I know from when I've worked in Rwanda and Uganda, then we routinely gave eye drops to all the babies. That was normal. But it's about the prevalence, the incidence, and also the surveillance that we have in the UK. So I hope that answers your question. Right, I think any final questions or comments, please put them in the chat. There's another comment there for your question, Jonathan, from Pamela about just the reason for stopping at 33 to 35 weeks was you continue until that time just because of your better neurodevelopmental outcomes. So any final questions or comments? So if not, I will just draw the meeting to a close. So I just want to say a really big thank you to Florence, Christine and Matthew for some really great presentations. It's been really good to share some practice and some learning. A big thank you to everyone for joining and for your participation, and I look forward to seeing everybody in June, and have a good weekend. Thank you.